So thank you all for being here. The meeting, there's a lot to see. And we are very excited about what's going on with LENSAR and with Ally. And Ally has really been an amazing improvement in what we can offer with femtosecond laser. So, in 2010 is really about when femtosecond laser came out. And as you can see, there has been an evolution. And we've had the opportunity to use LENSAR in our practice, which has really facilitated our ability to be very, very accurate with our astigmatism correction. So that's been a wonderful asset. But we're taking it a step further now with Ally. And Ally has taken all of the best parts of LENSAR and migrated those into a smaller footprint. So it's better for patients, it's better for surgeons. What we see is that proprietary astigmatism management tool, and I have tried all the different platforms that we have available in the US for iris registration and for accounting for cyclorotation when we're performing our astigmatism management. And really, far and away, this technology has allowed me to do that in a way that's simple, intuitive, fast, and comfortable for the patient and accurate for the surgeon. So that, to me, has been really the best benefit of integrating this technology into my practice. There's also wireless integration with pre-op devices, which allows for accuracy, maintenance of accuracy in our preoperative testing. I don't have to worry about, especially in today's environment, where we're very staff challenged, to have additional staff hours for making sure that we have accuracy in information, integration, and input. It all happens wirelessly, and it all happens automatically. It's very efficient with optimized lens fragmentation that you can actually marry to the density of the lens itself. So I can have a faster, simpler kind of fragmentation for very soft lenses. And then I have a very dense lens. I can easily have a different pattern that most efficiently will allow for softening of that lens. And it does it by the densitometry that is evaluated during the acquisition of the image so that it's automated. And the more things we have automated that I have to input less, the better it is for my flow, the better it is for consistency and effect, the better it is for my patient's experience, and the faster it is, actually. So I don't have to do a very complicated lens fragmentation pattern for a soft lens. And I don't have to worry that I've done too simple a fragmentation for a very dense lens as well. It's all very automated. And then, of course, it's pay per procedure. So this also is a practice builder as well. So as you can see, it automatically categorizes the cataract density. Not only does it do that in a way that marries it with all these predetermined fragmentation patterns, but I can see that too as we're acquiring the image. So I can look and anticipate how difficult the next case is going to be. So it helps with my mental preparation for the case as well. And then there's so many different ways that you can customize the pattern to your technique. So I like to do vertical chop. So I have a specific way that I like to fragment the nucleus, but maybe somebody else has a different technique that a different pattern of fragmentation works for them. So we have multiple surgeons in my center, and I can have each surgeon optimize the fragmentation for each density for their own technique in a way that remains the most efficient for them. So it's the first cataract laser that integrates all of these different critical planning and procedure elements so that it's already, you've thought this ahead of time. You've set it ahead of time. You have the machine now as an extension of your planning that you're doing in your brain. It knows those settings, it knows you and your technique, and it's setting up things the way you would want it set up if you had to have that sort of conversation during the femtosecond laser, telling your technician to change settings, or during phacoemulsification, also telling your scrub tech or your circulator what you want different based on the case. The machine and you are one unit now, that it's in your brain thinking like you do. And since it has that one-touch astigmatism incision planning, that also allows you to modify it based on your outcomes. So it can be customized to you and what you're trying to achieve. So again, if you want to alter your incision placement, or if you're somebody who never does that, or you have different parameters for when you wanted to do toric versus an LRI or combinations of the two, you can do all of those things. And it allows you to customize it, again, to your specifications, what you know works best in your hands, with your technique and your patients. Again, an extension of your brain into a machine. So iris registration, as I mentioned before, I think is the smoothest of all the platforms out there. Really, I would like to say never have I seen it fail. The only time I've seen it have difficulty is when the pupil is really widely dilated, so widely you can't actually see iris. And then I have had maybe one case I can think of where it really wouldn't acquire the image. But so for most of your cases, that's a seamless part where you don't have to be involved anymore. For me, that was the biggest time detriment to trying to do very accurate astigmatism planning and execution with my patients. And now it's something I don't even think about. I know it's going to be able to account for cyclorotation very accurately in a way that I can use intraoperatively to be effective and check postoperatively to look for rotation with IntelliAxis. So if we look at IntelliAxis and this report, we can see that 88.5% of patients with the refractive capsulorhexis, which, as you all know, is the fact that there are these little nubs in the appropriate axis for toric alignment. In those, 88% were less than a half a diopter versus 38.7% of manually marked eyes. So, I mean, manually marking eyes for me, again, it was a stressful part. I had to have patients cooperate. It wasn't a pleasant part for their experience in the preoperative area. It's just before they're going to go into the OR where you want them calm and having a wonderful experience. And it took time away from all the other things I want to concentrate on during surgery. So not necessary anymore. And because it's so accurate, the uncorrected distance visual acuity was significantly better in those patients. And not only that, as I mentioned, sometimes you get an unexpected result. And oftentimes it's because the ocular surface is not optimal. And trying to decide if residual astigmatism in the postoperative time frame is because of ocular surface disease versus rotation of the toric, when you have a mark that you're able to look at and say it's exactly where I left it, helps to answer that question and helps you to more aggressively treat the ocular surface and be more reassuring to the patient that that's actually the problem that's going on. And you can see it here in the image too, how easy it is to see that there's perfect alignment of the toric lens where you placed it before. So if we look at Acrosoft Toric and Vista Toric, pretty much all of the platforms we have in the United States, and Symphony, along with Arcuate Incisions, there was a very high level of numbers of patients, percentage of patients who were within a half a diopter of residual astigmatism at the completion of their surgery and in the postoperative period. So, I mean, these are amazing results when you see that, all in the 90s. Really incredible. So we can feel very confident in offering this as a benefit to our patients. So to me, this is the most exciting thing about Ally, because again, every small amount of time that you spend preoperative marking, even during the femtosecond laser, is potentially time that you can be treating another patient. So having something that is extremely fast, 2 to 4 times faster treatment, and flexible, it allows me to decide intraoperatively, do I need to do something before I do the femtosecond laser portion of it or not, such as pupillary expansion? This is a huge benefit to me. And so it has adaptive intelligence as well, just to make sure you're optimizing as you go on. You can also continue to refine your outcomes, continue to close that input loop, and improve outcomes over time. So here's some of the quotes of people who have had experience with Ally. So it's been exciting to see as we implement that the technology as we thought it was going to perform is actually performing as we thought. That's not always the case. But so Rob Weinstock, my neighbor just to the north, says that the speed is amazing, the images are amazing. Really, everything can be accomplished that we're used to doing fairly efficiently can be done in less than a minute in the femtosecond laser room, if that's how you designate to put it, or in the OR now. So now the OR cycle time was 30 minutes. They've been able to cut it down to 21 minutes, allowing at least one more case. So one more case is a significant improvement in the profitability, the ability to function in your ASC and continue to offer great care. So, and when you look at outcomes, there's actually already a large body of information showing that IntelliAxis improves outcomes, as we saw. All of those results in the 90 percentile within a half adopter for astigmatism correction. That's very meaningful. And doing that in the most efficient way with the smallest footprint without the need for additional rooms to house femtosecond laser, that's really amazing. So I think these comments that we see here are just what we're going to see in every site that has the opportunity to integrate Ally into their practice. And here you can see the procedure and see in real time just how quick this is. And you can see that this is a very customized pattern that this surgeon has decided is the best way to disassemble and fragment a nucleus for their technique with this density lens in this particular patient in a way that's very automated. So really incredible. So here we have an LRI, the second LRI, main incision, and really an amazing result there. So again, it's a compact system. It has the footprint of your typical phaco machine now, easily replacing older technology. It's mobile, can go into any OR, and really it's suited for any size setting for your cataract surgery. It's disruptive. It's the first in-kind technology. We have nothing else to compare it to at this time. And it easily adapts to whatever it is your technique is, whatever it is your workflow is, however you like to categorize your patients and treat, depending on if you want to use LRIs or torics or however it is that you want. And even within the surgery itself, whatever flow you decide you want to do with when femto is used in the phacoemulsification process. So that's a part of this that we're not used to even thinking about, that we have flexibility in the timing of the use of femto now within a cataract surgery. And again, very cost effective, reducing procedure time, allowing for more surgeries to be done. And with this mismatch between providers and the need for providers, this is going to be an important factor as well. Well, thank you very much. I'm super excited about Ally, and I know that you will be too.